Good morning. This is Charmaine Chu. I'm the chair of the healthcare practice team at Smith Halsey and Busey. Normally, on this day, our firm would be hosting its annual Healthcare Law and Management Symposium. We are very saddened this year that, of course, we've had to postpone due to the COVID-19 public health emergency. We wanted to take a moment to truly thank all of our healthcare hero clients who have helped our community navigate through this crisis. We applaud all of you, and we really value everything that you are bringing to our patients in our community. We are also happy to offer this properly socially distanced webinar so that our healthcare clients can keep abreast on state healthcare developments. Joining us today to present direct from the Capitol, Healthcare in 2020 Florida's legislative session is James McFadden from the Southern Group. James started his career as a senior legislative analyst at the Florida Senate Majority Offices. He's been Deputy Director of Legislative Affairs for the Governor, and he also headed ACA's Legislative Director's Office and served as its Chief of Staff. He is a graduate of Emory University and is based in the Southern Group's Tallahassee offices. And if you have joined us previously for our symposium, you know that he offers one of the most comprehensive state legislative summaries with insight that can only be known to somebody who is a true expert in the system. I'm going to turn the controls over now to James, who will have his slides on the screen. We thank him very much for participating and bringing this knowledge to us. And we also thank all of you for joining us today.
Hey everyone, thanks for tuning in, and I appreciate that introduction. And give me one moment, I'm going to share the PowerPoint presentation. Okay, I think we're set there. So as mentioned, this is what we're calling our Direct from the Capitol Florida Legislative Session Healthcare Update. And I'm with the Southern Group, a partner with the Southern Group. We're a lobbying and consulting firm with offices in Florida and Georgia, Alabama, South Carolina. We actually also have affiliated offices in Louisiana and Michigan. Up in Michigan, they go by the name Midwest Strategy Group, actually. And then here in Florida, we have 25 lobbyists in 6 offices around the state. That really allows us to better engage, if you will, with state legislators in their home districts, but also to function as local government lobbyists as well. And so I've been with Southern for about 8 years now. My focus is healthcare. A few of my clients include Florida Blue, CVS, McKesson, Tenet, Encompass Health, Florida Senior Living Association, which is the state's largest association for assisted living. And so obviously those folks are, and myself with them, are very involved right now with everything going on with COVID-19. MCNA dental plans, Autism Speaks. So you can kind of see it's a pretty varied healthcare client base. And so I get the opportunity to work in a lot of different varied topics and issues and budget items. We'll just get through this. So before I get into a discussion of the healthcare legislation resulting from the 2020 session, that's the purpose of this presentation. But I did want to address, the topic of COVID-19 in relation to our session. It'd be a little odd to do this presentation without doing that first. So Florida's session, it concluded on Thursday, March 19th. So it's been a couple of months now. It was originally scheduled to end the previous Friday, March 13th. But because of some trouble concluding budget negotiations, they ended up having to extend the session a few days. And that has almost become kind of normal the past few years. Our legislative session usually starts in early March. When I made this presentation last year in person at Ponte Vedra, we had actually just come out of the session, I believe the week before. So our session's 60 days long. Normally would have probably just ended either last week or this week. But because the legislature has been experimenting the past few years with having session 2 months earlier during election years, we started in January this year. That timing actually ended up being accidentally really good. And because even with the needed extension to finish the budget, Florida was able to successfully conclude our session in a fairly normal way. Many other states are actually still in session. The pandemic has obviously drastically impacted those states' ability to finish their work. Additionally, Florida's budgetary picture was, prior to the pandemic, a very healthy one. The new budget constructed this year that goes into effect July 1 did not have any Medicaid reimbursement rate cuts for providers. It actually saw nursing homes receive a rate increase and state employees receive a pay raise, both of those for the first time in years. Cash reserves were also beefed up to about $4 billion in total, billion with a B. The state has also the state has already determined that it does not need to implement any cuts to the current fiscal year's budget in response to COVID-19 impacts, thanks to the availability of reserves. And while it's most certain it will need to convene a special session at some point to address cuts to the new budget, it remains to be seen what those cuts may look like. Very early estimates predict we're looking at a $8 to $10 billion impact to our state budget at a minimum. Keep in mind things are changing by the day. For instance, just this week, the Agency for Healthcare Administration, my old employer, indicated increased cost to Florida's Medicaid budget due to increased enrollment and increased claims, resulting from the pandemic. That could be as much as $3 billion over the course of the coming year. About 2/3 of that would be federal money, so about $1 billion of that would end up needing to be new state funding, and that's even after accounting for the 6.2 percentage point increase in Florida's federal Medicaid assistance percentage. Most of us know that as the FMAP that was recently approved by Congress as part of the COVID-19 response. So that right there is $1 billion in general revenue the state is going to need to find, and that amount could grow. And then just last week, the state revealed the month of March's sales tax collections. Those figures were over $750 million less than expectations. That's about 25% less than what had been estimated prior to the pandemic should have occurred for the month of March. So, obviously it's impacting the budget on both sides, both from the revenues coming in the door and the funds going out the door. Of course, all the economic prognostication depends on how quickly Florida can get back to some sense of normalcy, considering our economy's dependency on tourism and sales tax. So if things go relatively smooth as the state moves through a phased reopening. Of course, we're in phase 1 right now. Most of us, Miami-Dade and Broward, sound like they're going to be able to open up next Monday. But anyway, if we're able to get through it smoothly, the hope is that thanks to Florida's Healthy Rainy Day Fund and the influx of federal assistance, cuts to the budget could be made by the legislature with a surgeon's knife instead of a meat cleaver. So that's kind of where we stand. With that, I'd like to get into the heart of the presentation, which of course is a discussion of the healthcare legislation that passed the 2020 Florida legislature, while the novel coronavirus was still something that really was a bit abstract on this side of the globe. So those of you who might have joined us last year in Ponte Vedra for my presentation may have seen some of these quotes. I focused a lot on the Speaker of House of Representatives last year, Jose Oliva. Speaker Oliva has not been shy the past few years about his disdain for healthcare laws and regulations that, in his opinion, really stifle competition and limit innovation and access to care. This session was no different. So, I actually went back and looked at my presentation from last year, and there was a slide that had these quotes from the speaker regarding his opinions on healthcare. All of these were said prior to the 2019 session, but really they could have been said by him just prior to the 2020 session, as his opinion had not changed very much at all. As a reminder, during the 2019 session, Speaker Oliva accomplished several healthcare top priorities, including the repeal of the Hospital Certificate of Need program. That had been a long fought battle. The passage of a prescription drug importation program, a bill establishing statutory framework for telehealth, legislation requiring increased healthcare transparency for consumers, and a repeal of the ambulatory surgical center's midnight rule, which would allow the ASCs to do more complicated surgeries or do surgeries later in the day as well. But as I mentioned, the speaker was not done. So in his second and final year of his speakership, Jose Oliva did not let up on his pursuit of healthcare reform. The Speaker, as well as his counterpart across the Capitol, Senate President Bill Galvano, they're both term limited this session as legislators. They're only allowed to serve 8 consecutive years in each chamber. Neither has any known future political ambitions, though it wouldn't surprise many to see Galvano reemerge at some point in a run for office. Oliva has made it clear, though, however, he is done with politics. And that fact really has been one of the reasons he has felt so unencumbered to pursue, with great success, healthcare reforms that his predecessors have either shied away from for political reasons or tried but failed to get across the finish line. Additionally, Governor DeSantis, Ron DeSantis, and the Speaker have enjoyed a good relationship for the most part. Oliva is actually one of the first prominent Florida politicians to publicly support DeSantis's run for governor during the primary, Republican primary against Adam Putnam. Speaker Oliva, of course, he doesn't achieve these successes without a strong supporting cast. Here are the legislators that make up his healthcare leadership team. The House has a much more expansive healthcare committee structure than the Senate does. Ray Rodriguez chairs the Health and Human Services Committee there in the middle. Like Oliva, Rodriguez is also term limited. He's actually running for the state Senate and is pretty much guaranteed that he's going to win that race. So he'll be in the Senate next year. A really interesting webinar would be the topic of COVID-19 on campaigning, its impacts on campaigning. Candidates are not allowed to fundraise during session. And of course, right as session was ending, we found ourselves in the COVID-19 pandemic situation. Usually us lobbyists we're used to immediately getting hammered on the phone by these folks for fundraising. And that really hasn't happened. I haven't received a single fundraising call since session ended. So that's really been about the only good thing about all this from my perspective. But anyway, underneath Rodriguez's committee, there are 3 subcommittees. Kerry Pigman, who's also term limited. He's going to be returning back to work full time as an emergency department physician. Pigman has carried the water for years on increasing the scope of practice for nurses. And as we're going to discuss in a few minutes, that ends up being really the central focus point of Oliva's platform this year. That's a bit unusual for someone like Pigman, who's a physician, to be such an advocate for scope expansion. The Florida Medical Association and other doctors groups have consistently been adamantly opposed to scope expansion. But Pigman has just always seen it as the right thing to do to try and let nurses practice at the top of their licensure and education. So Oliva entrusted the duty to Pigman again this year to carry that bill. Colleen Burton, she actually has 2 years remaining before she's termed out. So she's expected to play a really large role on the leadership team of the incoming speaker for the next 2 years, Representative Chris Sprouse from Clearwater. And then you have Mel Ponder. He's actually got 4 years left. He heads the Children, Families, and Seniors Subcommittee. And then Mary Lynn Magar, she is the chair of the Healthcare Appropriations Subcommittee. She's actually also term limited, as she has been in the House for 8 years as well now. On the Senate side, you've got Gail Harrell there in the middle. She's the chair of the Health Policy Committee. Interestingly enough, she has actually been opposed to scope expansion due to her long existing loyalties to the Florida Medical Association. Her late husband was a physician. So despite her being the chair of the Health Policy Committee in the Senate, she was not on board with scope expansion. Senator DeBook, one of the few Democrats in Tallahassee that has a chairmanship, which is a testament to the Republican leadership's trust in her. She oversees the Children, Families, and Elder Affairs Committee. And then Aaron Bean heads the healthcare budget duties as chairman of the Appropriations Subcommittee on HHS. And all 3 of these senators will be back next year. So as I mentioned earlier, this is the second and final year of Jose Oliva's speakership. I actually used the same slide last year to conclude my presentation. This year I'm using it to start the discussion on healthcare legislation that passed. And as I mentioned also a little bit ago, the primary focus this year for Oliva was scope of practice expansion. This was his top priority, and so we'll get into a conversation about how that turned out. So here's the legislation. This was, ALEVA's #1 priority. It passed as part of a larger bill, HB 607. As I said earlier, Dr. Carrie Pigman was the bill sponsor. And the name of the bill is Direct Care Workers, because as I mentioned, it actually had more in this piece of legislation than just nurse expansion, scope expansion. So, current Florida law requires advanced practice registered nurses, APRNs or aprons, however you want to call that for short, to practice under a written protocol with a physician. So this bill actually authorizes the APRNs who meet certain criteria to practice primary care or midwifery without physician supervision or a protocol. So this is better known as autonomous practice. So this is a big step for Florida. The bill also creates an advisory council comprised of APRNs, physicians, and the state surgeon general to make recommendations to the Board of Nursing on the standards of practice for such APRNs. The bill also prohibits an insurer from requiring an insured to access care from an APRN. So, health plans cannot steer you towards an APRN against your will. If you want to go to a physician rather than an APRN, then you're free to do that. The bill also creates a loan repayment program through the Department of Health for APRNs who are engaging in autonomous practice in order to encourage that activity. As long as they're practicing primary care in a public health program or serving Medicaid recipients or other low-income patients in a primary care shortage area. We have plenty of those here in Florida. Continuing with House Bill 607, the bill also actually expands the scope of practice for certified nursing assistants and for home health aides. It does that by authorizing the delegation by a registered nurse of certain tasks to a CNA or an HHA, including medication administration. And it also authorizes CNAs and HHAs to assist with preventative skin care, with applying bandages and nebulizer treatments. So, as I mentioned, this bill does more than just expand scope for APRNs. The bill does a few other things also, including requiring all nursing homes, home health agencies, hospices, and homemaker and companion service providers to complete a workforce survey at each biennial licensure renewal. And this is an effort by the legislature to try to better understand where workforce shortages exist in the healthcare industry. It also creates the Excellence in Home Health and Nurse Registry Excellence programs to award designations to home health agencies and nurse registries that meet those specific criteria. So that was really, like, as I mentioned, the primary piece of legislation that the speaker was pushing. This was a huge achievement for Speaker Oliva. It's something no one else, that plenty before him have tried to do, but no one has ever been able to succeed. So, but it wasn't the only scope expansion that he sent to Governor DeSantis for signature. The practice of pharmacy also saw an expansion of responsibilities and capabilities this session. And this kind of caught some folks off guard. No one was really talking about this leading up into session. There was a bill last year that sought to give pharmacists the ability to treat and test for flu and strep. Ultimately, one or the other of them was pulled out of that legislation, but that legislation ended up not even passing. So it was kind of a surprise that this more encompassing piece of legislation showed up this year. Current law allows pharmacists to administer vaccines and immunizations. They can assist with medication management, as well as inject certain medications within an established protocol with a physician. This bill, House Bill 389, is going to expand the scope of practice of a pharmacist by allowing him or her to enter into a collaborative pharmacy practice agreement, it's a mouthful, with a physician to manage chronic health conditions. So the bill does prohibit a collaborating pharmacist from initiating or prescribing a controlled substance, or from modifying or discontinuing any medication that is prescribed by a healthcare practitioner who does not have an agreement with that pharmacist. So they are trying to put some parameters around this. The bill also authorizes pharmacists to perform clinical or laboratory testing or screening for and treating of minor non-chronic health conditions, that's the key there, non-chronic health conditions, within the framework of a protocol with a supervising physician. And you can see that the bill limits this activity to the following that are listed here on your screen: flu, strep, lice, skin conditions that could be something like ringworm or athlete's foot, and then minor uncomplicated infections. And so the bill is also going to require the Board of Pharmacy to create a drug formulary that an authorized pharmacist may prescribe to treat such conditions, as well as adopt guidelines directing a pharmacist to advise a patient to seek follow-up care from a physician. The bill also authorizes a pharmacist to use certain lab or clinical tests, as well as any established screening procedures for which no test is available. So it's a pretty comprehensive piece of legislation. And again, as I mentioned, this kind of caught a lot of folks off guard. It wasn't something the speaker was necessarily talking about like he was the APRN scope expansion, autonomous practice. So it was quite a feat to get this passed as well. And I think his idea is that it will go a long way to assist or increase access to care, especially in more rural areas where a pharmacy almost always exists and is usually pretty accessible, but getting in to see a primary care physician may be more difficult, especially if the scheduling is backed up or something along those lines. So continuing with more pharmacy scope expansion, there was actually a second bill, House Bill 599 by Representative Ana Maria Rodriguez. This bill expands the consultant pharmacist scope of practice. So this is a little bit higher level of pharmacy practice than just a pharmacist. This is a consultant pharmacist. And that currently exists in law today. Currently, a consultant pharmacist obtains specialized education above that which is required for licensure as a pharmacist. The consultant pharmacist may order and evaluate clinical and laboratory testing, those two things, for a patient residing in a nursing home upon authorization by the medical director of the nursing home, and for individuals under the care of a licensed home health agency if authorized by a licensed physician, podiatrist, or dentist. That's the current law. This bill expands the consultant pharmacist's practice abilities by allowing him or her to enter into a written collaborative practice agreement with a healthcare facility medical director or Florida licensed physician, podiatrist, or dentist to provide medication management services. This is a big change. These services can be provided in the nursing home or home health setting, like what is allowed for current law with the clinical and lab testing. But also the bill will allow these activities to be performed in newly authorized settings, such as ambulatory surgical centers, hospitals, alcohol or chemical dependency treatment centers, inpatient hospice, or ambulatory care centers. And the pharmacist is also authorized by the new law to make a recommendation to a patient's prescribing healthcare practitioner. And the Board of Pharmacy is authorized to establish additional education requirements for licensure as a consultant pharmacist. Obviously, with all these increased abilities, there's probably an increased need for some education as well. So again, another huge change in the scope of practice expansion that really kind of crept up on people, but the speaker was able to get it across the finish line. So sticking with our theme of scope expansion for one more bill, House Bill 467 by Representative Cindy Stevenson. This bill expands the scope of practice for physical therapists. Currently in Florida, PTs are prohibited from using acupuncture if the needle punctures the skin. However, most other states allow that. They allow PTs to utilize this technique. It's called dry needling. And it's where the needle penetrates the skin to stimulate underlying trigger points, myofascial trigger points, as well as muscular and connective tissues in order to manage pain and movement impairments. Florida is actually only one of 7 states that prohibits that practice. So the bill removes that prohibition and authorizes the Board of Physical Therapy Practice to adopt standards of practice for the performance of dry needling. The bill also establishes minimum experience, education, training requirements for PTs who want to perform dry needling. And finally, the bill revises the scope of practice for PTs by amending the definition of the practice of physical therapy so that it more closely reflects the definition in the Model Practice Act that a lot of states mirror. So that's sort of a brief rundown, or a rundown, I won't say brief, but a rundown of the scope of expansion bills that the speaker passed Since scope expansion was a hotly contested issue for years, with various physician groups in complete opposition, Speaker Oliva actually made the calculated move of sending all the scope bills we just reviewed, with the exception of the physical therapist bill, to the governor the day they passed the legislature. Very unusual. And they all passed on the same day. So the same day that all these bills passed, with the exception of the PT one, they immediately certified and sent the bills to the governor. And then the governor then actually signed them that very same day as well. He signed them in the evening. Very unusual move, but it was probably done for two reasons. First, it prevented those who opposed the bills, like the doctors groups, from lobbying the governor to veto them. They just didn't have the time. And second, it really ensured that Oliva got his scope bills signed and not vetoed before he committed to tackling many of the remaining issues that were priorities of the governors and priorities of the Senate in the few days that were left in session. So, right up until the end, Speaker Oliva was really demonstrating his negotiation and political skills. It was a pretty shrewd move on his part. So the session wasn't just about scope of practice bills. I'd like to take a few minutes to run through a few other pieces of healthcare legislation that successfully passed this year. One of these dealt with reforms to the iBudget program. I don't know how many of you know what the iBudget program is, but it's the Medicaid waiver program that individuals with developmental disabilities can participate in instead of traditional Medicaid. And the program is administered by the Agency for Persons with Disabilities. And the different disabilities that would qualify someone to be part of the program are actually listed out in statute. There's a lot of stakeholder and media attention on potential reforms to the iBudget program entering into session. The agency has historically struggled with operating within its budget. There have been continuous waiting lists for services that number in the tens of thousands of individuals. And fear was really circulating that the program would be decimated in an effort to cut costs, try to rein in the spending, and that it could potentially even be carved into the Medicaid managed care program, which families and providers alike really opposed. They really like how the program has been set aside as its own unique program, and that was a choice that was made back when Florida moved to statewide managed care a few years ago. So Senate Bill 82 was filed by Senator Aaron Bean. As I mentioned earlier, he's the chairman of the Senate Appropriations Subcommittee on Health and Human Services. And the bill contemplated various changes to the iBudget program. The fact that the House, though, was not showing its cards by not filing a bill of its own only added to sort of this conspiracies around what was going to end up happening with the iBudget program. It was very odd that the House did not file its own bill. But ultimately, the Senate did lead the effort to implement some reforms. The House eventually agreed to take an approach designed to allow the state to better predict costs within the waiver program with minimal impact to existing service levels. The changes ended up including creating a standard definition of a significant additional need to judge supplemental funding requests and centralizing that process for consistency at the Agency for Persons with Disabilities headquarters here in Tallahassee. As well as the bill also requires waiver support coordinators to be employed by qualified waiver support coordination agencies. That was a little bit of a controversial part of the bill, but the agency and the Senate felt it was important to do that to make sure that waiver support coordinators were properly trained and best representing their clients' interests. So additionally, the legislature included new money in the budget to fund additional slots in the iBudget program. In other words, to buy down that waiting list I mentioned, which at times has reached 35, 40, 45, 50,000 people. So moving along to the Agency for Healthcare Administration's legislative package bill. This bill is always a fun sort of catch-all of fairly inconsequential tweaks to statute affecting the agency's various programs and licensure responsibilities. It's often referred to as a deregulation package. When I worked at the Agency for Healthcare Administration, we ran this package really for the first time that the agency had done it and managed to pass it. And every 2 or 3 years, they run another one to try and clean up statutes and whatnot, and really to try to focus on doing some deregulation as well. There's two things that can sometimes make this legislation interesting, though. First, occasionally a very substantive change will find its way into the package, maybe 2 or 3 substantive changes. And then second, sometimes too many substantive changes get amended into the bill, and it really ends up becoming a train that's just destined to fail. It just gets too heavy. Too many controversial items get into it, and it ends up dying. So this year, the agency did get its package passed. They made a very concerted effort to try to keep unfriendly amendments and ideas off of it. And oftentimes that requires having 2 really good, really strong bill sponsors. But it did pass, 109 pages of it. It's always one of the longer bills. And it passed in the form of House Bill 731 by Representative Danny Perez. And Representative Perez is actually most likely going to be Speaker of the House in a few years. So as I mentioned, a strong bill sponsor is also often very helpful. So some more of the significant changes include updates. It updates requirements for approval of comprehensive emergency management plans for newly licensed facilities. It allows AHCA to issue provisional licenses to all regulated providers and facilities, and that was actually a pretty significant change to allow AHCA that flexibility. It makes changes to inspection frequencies for high-performing and poor-performing facilities. So if you're a high-performing facility, you may see less regularly scheduled inspections. If you're poor-performing, you're going to see more. So that allows the agency to focus its surveyors, inspectors on the poor-performing facilities and try to elevate the performance there. Of course, if there's a complaint called in, they're compelled to go and inspect regardless if there's a complaint called in. So it doesn't impact inspections centering on complaints. The bill exempts from clinic licensure some different entity types: federally certified providers, community mental health center, partial hospitalization programs, portable x-ray providers, and rural health clinics, and also actually exempts from clinic licensure all Medicaid providers. That's a really, really big change. And the thinking there is that, well, if you're a Medicaid provider, you've already gone through a Medicaid provider application process with AHCA. AHCA knows who you are. And it's a bit redundant to also be licensed as a clinic because a lot of it is just the exact same information. So the idea behind that is to A, eliminate some workload on the agency, B, to eliminate workload on healthcare providers who are Medicaid providers already, and then C, also to encourage folks to participate in Medicaid. If you're going to open a new clinic, and you don't want to go through the clinic licensure process, which can be pretty cumbersome and not always guaranteed to work out, and also costly, we'll just get a Medicaid provider number, which can be a simpler process, and use that as your as the neck to choke, as we sometimes say, is what AHCA would use your Medicaid provider number as the way to go after you, for instance, if you're committing fraud or doing something wrong versus your clinic license. So the bill also requires AHCA to re-procure the contracts that it has with the Medicaid managed care plans and with the dental plans every 6 years instead of 5, and extends the existing contracts out an additional year. That was really focused or done because the agency, and it actually ended up being pretty fortuitous because of COVID-19. They didn't do it for that reason. We didn't know about COVID-19 at the time. But really, the agency's got a lot going on around re-procurement of its Medicaid management information system, which is a huge technology re-procurement. And there's some other re-procurements going on as well. They've only got so many staff. And so the idea here is to try to give the staff a extra year to push out the re-procurement of the Medicaid managed care plans, because that is a very labor-intensive process. And then also, there was just a feeling that 5 years might be a little too short. When they went through the first 5-year process or 5-year contracts, they realized that it really wasn't enough time to gauge quality metrics and that type of stuff. So 6 years may allow for better gathering of data, so that the Medicaid program overall can be improved. And then the bill also specifies that Medicaid anti-kickback prohibitions do not apply to any discount or payment or waiver of payment or payment practice that's not prohibited under the federal anti-kickback law. The Florida Medicaid anti-kickback prohibitions were stricter than the federal prohibitions, and so it's causing some confusion. So this was just a way to try to align what the state allows with what the federal government allows. If the federal government doesn't prohibit it, then the state's not going to prohibit it. So moving on to House Bill 767, this one's focused on assisted living, which is obviously, and this was a bill that I worked on closely. As I mentioned, I represent the Florida Senior Living Association. And really with the rapidly developing world of personal care technology, coupled with the growing assisted living facility industry, it's really booming, Florida especially. This bill was designed to modernize seniors' assisted living experience, to empower seniors with stronger consumer protections, to better manage their care, and strengthen ALF's ability to serve seniors as a residential model with a healthcare overlay. And that's an important distinction between ALFs and nursing homes. Nursing homes are they're healthcare facilities. ALFs are healthcare facilities as far as the way that they're licensed and whatnot, but really they consider themselves a residential model with a healthcare overlay. And in fact, much of the healthcare that's actually provided in assisted living is provided by third-party home health agencies or third-party hospice agency, third-party nurses. Oftentimes that's how seniors in an ALF get their care. The ALF itself actually doesn't provide it, which has actually caused some complications with COVID-19 because you've got we've actually seen situations where one home healthcare worker entered into multiple assisted living facilities over the course of a couple of days. Turned out that home healthcare worker tested positive for COVID-19, and they had to go back with contact tracing. And that's a popular phrase you've probably heard a lot about in the news lately. But they had to go back with contact tracing and test every resident and every staffer at those ALFs that home healthcare worker had come into contact with. Thankfully, in that particular situation, those that they tested were all negative, so that was good. So the key functions of the bill, they include authorizing resident use of something that's been defined as assistive devices. And assistive devices are devices that help residents perform activities of daily living, fall prevention, fall prevention. So like wearables, they have these wearables now. It's almost like an iWatch where it can actually predict when a senior may be starting to become unsteady on their feet and alert them. So that, perhaps alert them in time so that they sit down and don't have a fall. These are devices that might be used in a private home. Up until now, the statutes were so vague and so gray that ALS didn't know if they were allowed to be used in an ALF or not, and they were scared to do it in most cases because they were worried that the Agency for Healthcare Administration may ding them for that. And ACA also admitted that they didn't know. So, technology or the statutes just had not kept up with technology. And assistive devices can also help reduce on-the-job injuries. The primary source of injury on the job for a nurse or a healthcare aide is handling or lifting a resident or a patient, back injuries, that type of stuff. So there's all kinds of new technology now that can assist with helping a senior out of a chair or something like that. The bill also authorizes the use of technological advances for facilities to provide wonder and risk management and to further strengthen resident care, safety, and security. The bill allows residents to use, as I mentioned, items that they might use at home, like a safety belt, if it's prescribed by the resident's physician, if it's used in accordance with agency rules, and the resident is able to independently manipulate it. So think of the situation where a senior may need to sit in a wheelchair for a good bit of the day and has a tendency to nap off and may fall out of the wheelchair. In their own home, they could have a safety belt, Velcro belt, something like that they can manipulate themselves In the ALF, they're not allowed to have that. It's considered a restraint. And so this clarifies that no, if the resident's physician prescribes it, if the resident wants it, if the resident can manipulate it themselves, then that's going to be okay. The bill also allows ALFs to admit residents that require, and this is a bit of scope expansion, if you will, for assisted living, but the bill allows ALFs to admit residents that require 24-hour nursing care. And of course, they've got to be able to care for them properly. Some ALFs don't even have nurses on staff, so these are for particular types of ALFs. They could admit residents that are receiving hospice services. This was a bit of a loophole. So a resident in an assisted living facility that's already in the facility can receive hospice services, but a senior who lives in their home and is already receiving hospice services and then wants to transfer into an assisted living facility actually has to disenroll from hospice in order to enroll in the assisted living facility, and then it can re-enroll into hospice. And so it was just a bit of a silly regulatory snafu that this bill cleared up. So if you're already on hospice and you want to move into an assisted living facility, now you'll be able to. And of course, again, the facility has to agree to it, and the additional care needs to be provided by a licensed hospice, and some other requirements need to be met. And then the bill also allows ALFs to admit residents who are bedridden if they're bedridden for no more than 7 days, or for an ALF that has an extended congregate care license, which is the highest level of ALF licensure. The resident could be bedridden for no more than 14 days. This solves a situation where someone may be getting discharged from the hospital after a surgery or a fall, and typically the ALF may not be able to bring them back in. They may have to go to a nursing home or rehab first. In the meantime, they may lose their spot at that assisted living facility. So this is meant to allow for residents who are temporarily bedridden to go ahead and be discharged back to their assisted living home. And then the bill also allows for more efficient assisted living facility operations. It avoids some duplicative and conflicting regulatory provisions across multiple inspecting agencies. So think about Agency for Healthcare Administration going in to inspect the facility, Department of Health going in to inspect the facility's kitchen, and you can get some conflicting results from that. It also consolidates some fire safety provisions and conforms some outdated terminology. And then it also removes a controversial requirement for ALF staff assisting with the self-administration medication. They were required to read the label of the medication aloud to the resident. And you can imagine that could create some privacy issues, some embarrassment, some just general annoyance for the senior if they know what the medicine is and they have to listen to it be read out 2, 3, 4, 5 medicines every single day, multiple times a day. So instead, the bill now requires staff to just in the presence of the resident, confirm the medication is correct and advise the resident of the medication name and purpose. So that's all now they'll have to tell the resident is, okay, Mrs. Smith, this is your medicine. Here's your medicine's name. Here's what it's for. I'm sorry, not purpose, dosage, medicine name and dosage. So just real quickly, a few other key pieces of healthcare legislation that passed the legislature this year. I want to run through those. House Bill 747. This one, it was actually appropriately numbered 747 because it has to do with air ambulances. This bill was designed to address the balanced billing situation with out-of-network air ambulances. Some of you may be familiar with this situation. So the bill requires a commercial health insurer or an HMO to provide reasonable reimbursement to an air ambulance service for emergency and non-emergency transport services that are provided to a covered individual in accordance with the terms of the insurance policy or the HMO contract. And further, the bill prohibits air ambulance service providers from balance billing insured patients. So that payment that they receive from the HMO or the insurer is the payment they're going to receive. House Bill 763, and I will say there were some horror stories around air ambulance balance billing where someone is in a car accident, has no choice obviously as to what air ambulance shows up, has no idea if that air ambulance is in network with their insurer. If they're unconscious, it's not like you're going to turn it away anyway. So it was really creating an odd situation where after the fact, a patient was getting balance billed for tens of thousands of dollars for that air ambulance transport. House Bill 763, patient safety culture surveys. This bill will require hospitals and AmSurg centers to use the hospital or ASC survey on patient safety culture, as applicable, to conduct anonymous biannual patient safety cultural surveys of facility staff. This bill's been around for a few years. It's always been fairly controversial. I think it got into a mode this year where hospitals were okay with it, especially the fact that it was going to be anonymous. It was only every 2 years. And then the data does have to be submitted to AHCA in a format specified by rule. AHCA is going to publish the survey results for each hospital and each AmSurg center in the aggregate and by composite measure, and for hospitals by unit work areas. So all that information will be available to consumers, it'll be available to researchers, policymakers, whomever. House Bill 1179 prohibits healthcare practitioners, healthcare facilities, and any other entity responsible for potential recipients of anatomical gifts from taking specific actions against an individual with a developmental disability or an intellectual disability who is eligible to receive an anatomical gift based solely on the fact that they have a disability. The bill also requires such entities to make reasonable accommodations in their policies, practices, or procedures to allow a patient with a disability access to services unless it is demonstrated that making the modification would fundamentally alter the nature of the services. So this was trying to get at a bit of discrimination that was alleged to be occurring around anatomical gifts and persons with developmental or intellectual disabilities. And House Bill 1189 by Representative Chris Sprowls. This bill is going, and as I mentioned earlier, Chris Sprowls is going to be the new, actually I haven't mentioned it yet, but he's going to be the new Speaker of the House, replacing Jose Oliva. But House Bill 1189, this bill actually received the nickname the 23andMe bill, but it expands existing state prohibitions on the use of genetic information by insurers to include entities that issue policies for life insurance, long-term care insurance, and disability income insurance. These insurers are prohibited by the bill from canceling, limiting, or denying coverage, and from setting different premium rates based on personal genetic information without a specific diagnosis related to the genetic information. So it's a bit of a nuance there. The bill also prohibits these insurers from requiring or soliciting genetic information, using genetic test results, or considering a person's decisions or actions relating to genetic testing for any insurance purpose. The bill expressly provides that it does not prevent life or long-term care insurers from accessing an individual's medical record as part of an application process. And likewise, a life insurer or a long-term care insurer is not prohibited from considering a medical diagnosis included in an applicant's medical record, even if the diagnosis resulted from the use of genetic test. So again, it's getting to, okay, genetic information can be used if it's part of an actual diagnosis, but an insurer just can't access, 23andMe results and use that to price premiums or deny coverage or anything like that. And then Senate Bill 1344 by Senator Gail Harrell. This bill establishes a new certificate of need exemption for an intermediate care facility for the developmentally disabled. So it's repealing the CON or creating an exemption from the CON process for those types of facilities that are for use by individuals exhibiting severe maladaptive behaviors and co-occurring psychiatric diagnoses who are requiring increased levels of behavioral, medical, and therapeutic oversight. This is an effort to try to get more of these facilities established. And the bill dictates that AHCA shall not grant more than 3 such CON exemptions, and the exemption terminates 18 months after issuance if construction has not commenced yet. So that was just a quick rundown of a few more. There are a couple dozen more healthcare related bills that passed this session. This was just a selection that I chose to highlight today. And then as for the budget, I did want to touch on the budget quickly. The fiscal year 2021 budget crafted by the legislature totals $93.2 billion. It's an increase of $2.2 billion in total spending over the current fiscal year. That's 2.4% increase. And that represents a $1.2 billion increase in general revenue funds, which is about a 3.7% increase. 42% of the budget is health and human services. You can see it's the largest piece of the pie there. I don't really want to spend a whole lot of time here as what the budget looks like right now is going to likely be altered drastically when the legislature inevitably comes back for special session to deal with the pandemic. But I did want to point out a few highlights from the HHS portion of the budget. So the Medicaid caseload was expected prior to COVID-19 to be around 3.8 million recipients and 3.8 million Floridians in Florida. The caseload trend has actually been slowly creeping downwards the past few years. It got up to around 4 million, a little bit over 4 million recipients at one point. But that is expected to occur during good economic conditions, even with our population growth in Florida. As the economy is increasingly better, those who rely on Medicaid, decrease, that number decreases. But COVID-19 is obviously going to make the caseload swell. People are losing their jobs and therefore also probably losing their insurance. And so as I alluded to earlier, with increased enrollment and with increased claims experience, accounting for at least $3 billion in additional expenditures, another $1 billion at least in state funds is going to be needed for the Medicaid program for the fiscal year starting July 1. Nursing homes, they actually received a total Medicaid rate increase of about $105 million for nursing care center. The $74.8 million you see here does not include another $30.4 million in increased federal matching funds from the nursing home quality assessment that will take place on October 1st to coincide with the new Medicaid rates that reflect updated quality scores and that type of stuff. So about $105 million increased rate for the nursing homes. There's a few others, just real quick. The drug importation program funding. I mentioned that as a bill that was passed last year, creating the Canadian Prescription Drug Importation Program. Here's the funding that will be provided this year to get that program going. And then the funds for the iBudget program. This gets to what I discussed earlier about reforms to the iBudget waiver program to address the historical tendency of the Agency for Persons with Disabilities to run massive deficits, and then also some funding to try to whittle down that continuous wait list for services that the agency always experiences. And then some other initiatives here for Alzheimer's disease and home care for the elderly. So in conclusion, I mentioned previously that Oliva and Galvano are in their final year of a 2-year stint of leading their respective chambers. Here are the two gentlemen who will take the gavel after the November election. Representative Chris Sprowls, who I mentioned earlier in the context of the 23andMe bill, the genetic bill. He's an attorney from Clearwater, and then Senator Wilton Simpson, who's a businessman from Spring Hill. He's actually an egg farmer. He's got several businesses, but if you buy eggs from Publix, you're probably buying eggs from his egg farm. I've actually visited it. He's got about 3 million chickens. But anyway, these two gentlemen, they face some huge challenges that they could not have even begun to envision when they were designated the next Speaker of the House and the next President of the Senate last fall. It's possible we still can't even envision the task that they'll need to accomplish, as so much uncertainty surrounds how Florida and the nation will fare as we begin to reopen. And if a second wave will indeed come in the fall. Challenges as simple as how do you even convene a legislature if we're in a quarantine lockdown situation again. So, with that, I'll conclude this presentation. I hope it's been informative. I'm happy to answer any questions, and I will stop sharing my screen now, I believe.